The views and opinions expressed on Coffee and Compatibility are those of the podcast host and do not necessarily reflect the official policy or position of ASHI.
Welcome back to Coffee and Compatibility. Today, we are joined by a true leader in transplant immunology and laboratory medicine. Professor Medhat Askar is joining us direct from Japan. He just arrived in Japan. It's like 2 a.m. and he's recording with us. And he was just in Geneva also. So we're so lucky to have him today. Dr. Askar has been with us before, but I have to remind you that he is a physician scientist specializing in transplant immunology, cell and gene therapy, and HLA. He currently serves in several national and international leadership roles, including advising the National Marrow Donor Program and the World Health Organization. He is also a past president of ASHI and ABHI and has dedicated his career to advancing education, quality, and innovation in histocompatibility and transplantation. Dr. Askar, it is so amazing to have a rock star like you back on the podcast.
Thank
May
you.
we call you Medhat?
Yeah, absolutely.
Oh, thank goodness. Thank you. Yeah. Oh, poor Anne. Anne is working so hard and she's trying to train me up. I am originally remembering that we invited you to talk about HLA practitioners needing so badly to get involved in cell therapy. And that is where we're going to go. But I can't pass up the opportunity to ask you what happened in Geneva. You spoke to the World Health Organization. Tell us about that experience.
It's really because of the withdrawal of the United States. I don't know how to put this in a more politically correct way. From the World Health Organization, they lost 20% of their funding. And as a result, they are consolidating programs and eliminating some of the programs, actually. And transplantation has not been on the World Health Organization for long because it has always been looked at as something esoteric, affects few patients, so complicated, so expensive, that doesn't really rise to the level of being public health priority, let alone global public health priority, which is the domain of the World Health Organization. But now, with the 17 UN Sustainability Development Goals, one of them is goal number 3 that has to do with health and well being. And they set very ambitious targets for 2030 to reduce premature mortality from non communicable diseases by third by year 2030. So, what is mortality from non communicable diseases? It's cancer, it's end stage organ failure, it's heart failure, it's all conditions that are addressable by transplantation. So, it became clear that it is not possible to achieve these targets without integration of transplantation into country level universal health coverage strategies. And this really was the heart of the presentation, the statement of the International Transplantation Society, TTS, that I had the privilege of delivering, is that WHO has to integrate, or at least urge countries to integrate these policies into their universal health coverage strategies. This year, actually, we followed up on that, and we wanted the WHO to remain reminded of how critical transplantation is. So we actually explained what this looks like. So when we say that countries need to integrate universal health, what that looks like, and we said that they need to have to designate specialized authorities within ministries of health to actually oversee and regulate transplantation and to follow guidelines and have reporting mandates and the structured biovigilance and all the factors that are essential for establishing safe and effective transplantation. And we summarized our statement by saying that transplantation is really integral part of modern healthcare systems, and that the TTS is actually ready to support the WHO in this integration.
Well, thank you so much for speaking out for the whole field in that setting. That is so important. We want to talk to you about cell therapy for sure, right? Kelly mentioned earlier that that's really a specialty, and I think I'm probably in the same boat as a lot of people in that our attention has been on transplants, right, for the majority or the entirety of our careers. So for those like me whose attention has been on transplants, what do we need to know about the role of HLA in cell therapy? Take us to school if you would.
Yeah, so before we get to that, I think it will be helpful to explain the context, where cell therapy is going, so that because I think you need to go where the buck is going, nor where it came from, this analogy. So really, if we follow the trajectory of cellular therapy, in 2023, the global market was about 20 billion US dollars. It is projected in 2030 to reach 180 billion. So there isn't anything in the history of medicine that has been growing that exponential. And where this growth is going to come from? Until thus far, or maybe until maybe 3 years ago, cellular therapy like CAR T cells and CAR NK cells and alike were targeting hematological malignancies. And this is where they achieved most success. But then it was clear that this platform is much, much more powerful and can be utilized in non-malignant applications, specifically autoimmune disorders like diabetes, rheumatoid arthritis, systemic lupus. There was an article from New England Journal of Medicine from a group in Germany that actually, in essence, cured systemic lupus. When did we ever even dreamed of such a thing? They show there is no autoantibodies, there is no clinical manifestations, and this is using the same CAR T cells, CD19 CAR T cells, that just wiped out all B cells. And when B cells came back and the immune system was reset, the patient was cured from this, or at least in indefinite remission, if you may. And if you look at the proportion of patients with autoimmune diseases and non-malignant like diabetes mellitus, or even other diseases that are not compared to the malignant disease, hematological malignancies, they are 100-fold more, because we are lucky that cancers, we think they are a lot, but actually in the major scheme of things, they actually rare diseases, if you may, compared to other entities like autoimmune diseases. So this is going to be a huge increase. Accompanied with this is the change in technology. Now there is a realization that making one product per one patient in an autologous setting is not going to be conducive to access at affordable rate and at pace that is commensurate, with making this a treatment for the public, for large number of patients. And that's why came the idea of having off-the-shelf universal donors that are ready to use once you diagnose the patient. And for this, you need to overcome the immunological barriers that we had with bone marrow transplantation. But we want to use them leveraging the new technologies of gene editing and the like.
No, I think you're You're absolutely right, Medhat. I'm wondering if you can expand on, some of the challenges that you're touching on about how we can use, the modern technology of CRISPR-Cas9 and other gene editing techniques in connection with, some of the things that the audience is going to be familiar with to move the cellular therapy forward.
So there are a number of strategies, and different groups are trying different things. So the idea is, if you have these cells, these allogeneic CAR T cells expressing the HLA normal like any other cell, they're going to be attacked by T cells. Okay? It's as simple as that. They're not going to survive. They're not going to do anything useful. If you eliminate HLA completely, they're going to be attacked by NK cells, and they're not going to do anything useful. So what do? We are between the rock and the hard place, okay? And actually, we have an article with a colleague from Case Western Reserve review article that just came out, I think, last month, Rajdeep Das, that talks about strategies for mitigation of HLA incompatibility in the settings of uh, allogeneic CAR T cells or immune effector cellular therapy. So we really need to do something that is Goldilocks type of situation that hide enough from T cells but doesn't upset NK cells too much. So one of the strategies was either to eliminate the class 1 and class 2, but up the expression of CD47, so that would keep the NK cell happy, so not very upset, or any combination. There are really number of strategies. I don't think it is the point of listing all of them, but this is what you need. You need something that hides enough from, be hidden enough from the T cells, but somehow doesn't upset the NK cells. And the solution might actually be is something that not completely hide it. Maybe you need minimal level of immunosuppression, which could be like a hybrid model. So you avoid the calcineurin inhibitor, the big ticket, heavy side effects, but still not disturb, because everything we edit really disturbs something. So not do massive editing when you do this.
Medhat, do we know what happens to patients from an antibody or an immunologic perspective outside of the reason they're being treated? Do we know what's happening to these patients that get allogeneic sources of cell
So
therapy?
there hasn't been that much allogeneic going on yet to tell that. So I don't think it is clear at this point.
A lot of this sounds so familiar. I feel like we've been here before. Do you feel that way?
Yes, yes, absolutely. Absolutely. And I think really this is really the opportunity. I mean, if all projections come to fruition, there will be more allogeneic CAR T cells activities going on than transplants. Because just by the sheer number of patients that can benefit from immune effector cells that will be allogeneic. So I think it's really the opportunity for our field to be ahead of this wave and educate ourselves and be engaged with clinicians, with policymakers, make sure that there are regulations that require appropriate testing to make sure that these products are safe and effective. Because if you develop these antibodies and they attack the cells, the least that can happen is that they will be eliminated and the treatment won't be effective. But at worst, they actually could trigger, autoimmune mechanism, or they could trigger any mechanism that would actually become unsafe, not just not effective.
Yes, I mean, we should be typing these products and we should be typing our patients and looking for
Testing for
compatibility
antibodies
of
against them,
certain
yeah.
products, right? Just like we do for other things. One complication that I see here that we've talked about before that I think is so important is I don't think people doing cell therapy right now realize the need for this coming the way that we probably see it, the way that you have seen it and verbalized that you see it. Sometimes the hardest thing can be legitimizing the need for a party or a group or testing to be inserted into a process. What is your vision for HLA laboratorian involvement or ASHI involvement in this oncoming growing process?
I think the manufacturers and clinical trialists and people in this field have some justification of being worried about engaging more key stakeholders than they absolutely need, because FDA is going to hear about this, they're going to go crazy on them, and they want to do cross-match, prospective cross-match on every case, and they want to do, all kinds of crazy things that are neither required nor even helpful. So we really need to have rational conversation with them to assure them, no, we are not here to shut you down. We are here to make you more effective and make you aware of some of the blind spots that you might not be aware of that will overall limit your success. And I think if we have it from that perspective, we don't want to do more testing than we absolutely have to. The same way we don't want to do this in transplant or any other setting, but we want to do the testing that is going to help you to make your treatment more effective and safer. I don't think anyone would be opposed to that, but they just worry that they don't know what will be the outcome if they engage with us.
How far away do you think that is, where we're actually doing testing in our labs for
Now,
this?
I think that's happening now. We need to be engaged now. We need to talk to manufacturers. We need to increase awareness among clinicians. We need to educate ourselves also, because I believe some of us might not be as well versed in this revolution that is happening as we speak right now.
Yeah, that's what I was going to highlight is I think, we talk about it here and there in pockets, right? At the annual meeting, it comes up often, but can you give us your thoughts on how do we spread the word so that not just like pockets of individuals are familiar with this, but like we all have the right language and approach to go to the manufacturers to have these conversations, as you're sort of leading the way?
I think this is really the most complex thing, but I don't think it is undoable. I think we need to come up with a strategy, but I don't think that should be the calling of one individual. I think we need to create like a task force or group of people who are, you're saying, like, experienced individuals in this field, and they come up with a communication strategy. I think that's what we need. We need a communication strategy with lab directors, and communication strategy with clinicians, communication strategy with the FDA, communication strategy with fact, communication strategy with companies. That's what really needs to happen.
Yeah, because getting in like when these trials are happening. So from what you're describing, the amount of allogeneic data is very slim. So
Because they don't do testing. They don't want to know about it. They think
yeah, so we
they're
almost
following the
need to
school
get
of
in
thought. What you
there.
don't know cannot hurt you.
Ah! Oh yeah, we've been there before too, right? Until you discover that what you don't know can hurt you. Yeah, so it's like we need to put out all these feelers to these other regulatory entities. Is this rising to the level of potential legislation yet? I mean, we talk about cell therapy is pretty individualized in its generation approach too, right? So where's legislation at in this area?
I'm not aware of any like legislation, if you may, but I think FDA would be very interested if, again, because we only get one shot at this. We cannot mess this up. We tell them incoherent things or, opposing opinions and things like that. That we don't know how this ends. I mean, like, really, it could be very like a setback to the field, if you may, and we don't want that. So we need to have very well articulated, evidence-based conversation with FDA we need similar conversation with fact. I would start with those. And I think from there we can go to manufacturers after that.
Yeah, so you mentioned something really important right there, which is fact, right? For those who are not aware, right, fact is the foundation for the accreditation of cell therapy. And you are currently serving as ASHI's liaison. Can you explain a little bit more what that role entails and what ASHI's relationship is with fact?
So, FACT has this brilliant idea that I really, really appreciate. They have a committee, they call it Professional Relations Committee. And it has liaisons from all national, and by national I mean American, and international societies that are involved in any way or shape or form with transplantation or cellular therapy, and the ASHI is one of them. So it is bi-direction liaison relationship. So I communicate to that entire group or universe of societies that are stakeholders in transplantation cellular therapy, anything of relevance happening in ASHI to them. And also I take back to the ASHI leadership anything that is happening within any of the societies that are members of this committee.
Does that include questions, Medhat? This is something I've always wanted to know too, because I know so few people, because of the autologous nature of where the technology is right now, so few people are really involved in it. We actually have a partnering hospital that is generating cells for cell therapy, and they will send us samples to HLA type, but they don't tell us why, right? We kind of know what's going on, but they don't tell us why. They're just like, we just want HLA A locus typing for this for reasons we won't tell you. Right. So as this is going on, should we be sending, questions like, is FACT interested in generating data that's lacking for this aspect? Is FACT interested in, connecting ASHI expertise with people who are doing trials? Are these types of things that FACT wants to know? Because we don't have a lot of data to generate data-driven, initiatives.
It is not really the scope of operation of FACT. FACT is not like ASHI. FACT is dedicated society to accreditation. That's all they do. So they are very much like combination of ASHI, ARB, and the Quality and Standards Committee. That's what they are. They develop standards for practice and they apply them. They inspect people against these standards and they accredit them. That's all. They are really not in the business of research or gathering evidence or any of that. I think that could be the scope of one of two societies, the International Society of Cell and Gene Therapy or the American Society of Cell and Gene Therapy.
That makes sense. I have to circle back to it because it's going to eat me up inside if I don't. Do you think this has the potential to open up a whole new FDA can of worms? Or is it possibly because I think, the FDA holds discretionary enforcement over a lot of histocompatibility things. And we like that. We like to not be seen. On the other hand, if we get involved in this from an FDA perspective, is it a chance for us to move some things forward that the FDA does take discretion over, but hasn't moved forward in a while? Like the fact that we're still typing transfusion support cases with SSO instead of next generation sequencing or third generation sequencing. So like where do you feel like that lies from a task force perspective? The people are going to have to be eloquent.
You know what they say about this? Prediction is hard, especially of the future, and even more so with the FDA. So really, there is no telling how the FDA would go with that. But me, as Medhat, I never operate of fear. I think we should do our due diligence and we deal with the current situation. It will always open doors and we deal with it.
So can I ask, and forgive what's perhaps an overly simplistic question, but I'm trying to
These are the
wrap
scary ones.
I'm trying to wrap my head right around the what would be the best way to test and to test these products and the patients who receive them. So correct me if I'm wrong, but it seems like you're saying we should be HLA typing these cell therapy products and basically treating the cell therapy product as if it was an organ donor, and then testing the recipients similarly to how we would do a transplant patient. So is that correct, first of all? And then secondly, would this be most like a solid organ case or more like a stem cell bone marrow case?
I wouldn't go that far. I wouldn't here while we are sitting develop a protocol for testing allergenic cellular therapy products. But I think it is legitimate to create a committee of experts that would just to go over the evidence and decide what tests to be performed for which patient at what time points and in under what clinical context and to answer which clinical questions. I think really it is not as simple as us sitting here and saying, let's test this for this and that. But I think this exercise, this scientific exercise needs to be done.
Medhat, thank you so much for being with us today. I appreciate all the time and the effort that you are not only doing to be here with us today, but that you've put forward to push cellular therapy and to bring ASHI to the forefront. So thank you very much, sir.
Thank you very much for having me. I really appreciate it and I enjoyed the conversation.
Get ready for the must-attend event of the year in transplant science and immunogenetics. The ASHI 52nd Annual Meeting in Montreal, Canada, October 26th through 30th, 2026. Join world-class scientists, technologists, and innovators for cutting-edge workshops, interactive sessions, and breakthrough discoveries that are shaping the future of HLA and histocompatibility. Connect, learn, innovate. Whether you're a seasoned professional or emerging leader, this is the place to expand your expertise and spark new collaborations. Don't miss out! Be part of the conversation driving better outcomes for transplant patients everywhere. Register today and be inspired at the ASHI 52nd Annual Meeting.
All right, y'all, it's time for Tech Talk, the part of the show where we highlight a technologist and their work and their contributions to the field. And today, we're spotlighting Corey Crawford, HLA Data Coordinator at the Histocompatibility Lab at VCU Health in Richmond, Virginia. Corey's played a major role in improving laboratory workflow, automation, and data integration within his lab, from implementing new HistoTrack processes and improving specimen accessioning to integrating tools like AlloSeq Assign, Matchit, Fusion, and NanoDrop into laboratory workflows. His work has helped reduce manual entry and improve efficiency and accuracy across the lab. Most recently, Corey helped lead the onboarding of a new customer through Epicare Link integration, creating a more streamlined system for receiving orders and reporting results directly through Epic. He's also known for being calm under pressure, detail-oriented, and an excellent resource for antibody analysis and staff training. Corey, thank you for all the incredible work you do behind the scenes to keep the lab running smoothly and efficiently. Well, thanks so much, Corey, and thank you for all your work to support HLA and our field in general and all of our patients who rely on us. Thanks, Corey.
Well done.
If you need career advice or advice on how to deal with something happening in your lab, visit our podcast page at ashi-hla.org/page/ASHI podcast, or you can email us at info@ashi-hla.org and write the TEA in the subject line.
I think Medhat is one of the greatest guests we have had, simply because the knowledge that he has is so interesting to hear him talk about. Not only the involvement with the WHO in pushing that like transplantation as an entire entity forward, but then the stuff with the cellular therapy is just, it's forward thinking. It's fascinating to me.
Yeah, and I mean he's so right. Like right now
Yeah.
we're not in the allogeneic world with regularity there, but that's got to be the next iteration. The autologous, we've been down these paths before. Autologous infusions can't fix everything. We're going to need consistent products that are reproducible to bring this to the masses. That's going to require HLA labs in some form or function. So we need to be thinking about what that looks like to accommodate it appropriately and start, talking to those entities. Oh, those
I
three
know. Well, so here's the
programs.
thing, though, right? Is if we don't, right? Because it's coming. And if we
Oh,
don't take a position and start to be involved in the process, someone else will, right? Like some other regulatory body, other lab that we, right, will take that position. And that's not what I think is going to be best for the field and the patients, right? And so I think it behooves us as a community to sort of catch up a little bit.
yeah, absolutely. So folks, put your thinking caps on. This is where we're going. This is where we need to be. So yeah, we're gonna have to take it there.
I appreciate it. Just I felt like I was very uneducated about this topic, even on a very basic level. So I appreciated him breaking it down for us a little bit, and giving us the basics.
I
I
mean,
know
that's what
I
we need.
Yeah. Yeah. And folks, we will be linking. I think Medhat is going to share with us some of his WHO adventures. So we'll be sharing that. And we'll try to dig out one of the publications that he mentioned and link that to the show notes as well for you. Other than that, we got some quick reminders. I think ASHI University will officially transition to the new Path LMS platform in August of 2026, which is like tomorrow at this point, right? 2026 is blazing by. So the really important part here is if you have certificates or CE documentation that you would like to keep from the current Learning Builder platform, it will not transition into the new Path LMS system. You've got to go in there into Learning Builder and download your pre-existing certificates and CE documentation before August 1st. So there are step-by-step instructions for downloading your certificates on the ASHI education page at www.ashi-hla.org/page/education.
Also, coming up soon here is the ASHI Educational Workshop. That is happening June the 4th through the 6th in Austin, Texas. And everyone says that Austin rocks. So you definitely want to go. AEW is a great opportunity for technologists, supervisors, and newer professionals to learn foundational concepts, emerging technologies, and practical applications directly from experienced faculty. You can find all the information for that AEW meeting and all upcoming meetings at ashi-hla.org and click on the meetings page.
And one last friendly, very important reminder, ASHI Board of Directors elections and proposed bylaw revisions are now officially open for your vote. The voting is electronic this year. It's easier than ever. I have done mine. It went so fast. If you are eligible to vote in the election, if you are an eligible ASHI voting member, you should have received your electronic ballot by email. The voting closes on July 31st. So make sure your voice is heard. Vote in the election. We need your vote. We want to elect the people that you want to see on your ASHI board.
Don't forget to subscribe to our YouTube channel. All right, guys. Until next time. Bye.